We get a ton of questions about statins. It's one of the most asked about topics. So we're going to make a whole series of videos on them, going over all of the evidence. Today we look at efficacy. Do statins work? And in the next videos in the series, we'll look at safety, potential side effects, funding concerns, etc. Now let's get something out of the way real quick. Anytime we talk about statins, people ask about conflicts of interest. And I think it's normal to ask, it's okay to ask. So I don't make a dime from statins. I've never made a cent from statins my entire life. I have no affiliation with industry, with any commercial entity. I don't care who makes money off of them. All I care is that people are healthy and well informed. And as always in these videos, I'm not going to tell you that you should or shouldn't be on a statin. That's not my turf. That's your decision to make with your doctor. My job is to give you access to scientific information so you can make an informed decision. Now, statins have become a very emotional topic online, and as such, we see the usual artificial polarization that we see with any emotional topic, with people on one side saying everybody should be on a statin and they should be added to the water supply, and on the other extreme, people saying things like statins are killing us and they're poison and nobody should take them. Neither of these views are supported by evidence. Most people just want facts so they can make a decision, and they go online looking for information and they're exposed to this type of messages. So in this series, we're going to show you the evidence. And I'm confident we're going to show you evidence that you've never been shown before. So let's get right into it. Do statins lower cardiovascular risk? And if so, by how much? This question has been asked many times by running large clinical trials with thousands of subjects. Half take a statin, half take a placebo. Dozens of these trials have been pooled together and analyzed. That's called a meta-analysis. So for example, one of the largest meta-analyses looked at 26 such randomized trials, including almost 170,000 people, and found a 22% lower risk of cardiovascular events. Events means heart attacks, strokes, etc. Cardiovascular bad outcomes. Okay, 22% lower risk. What does that mean? This is the overall average, but it's not a number set in stone. Risk is determined by two major factors. One is dose. The 22% lower risk is per millimole per liter reduction in LDL cholesterol. Okay, what does this mumbo jumbo actually mean? Well, cholesterol is measured in units, just like every parameter in your blood work. In some countries, like the UK, it's measured in millimoles per liter, and your LDL cholesterol number might be a 2 or a 3. It's a smaller number. In other countries, like the US, it's measured in milligrams per deciliter, and the values are usually 90, 110, so it's a larger number. I know what you're thinking. Why can't they all just sync up and use the same darn units? I'm with you. Okay, so it's 22% lower risk per millimole per liter LDL cholesterol lowered, which converts to about 38 points in the US, 38 milligrams per deciliter. So 1 point lower in the UK, 38 points lower in the US. So if I lower my LDL cholesterol by 38 points, let's say from 138 milligrams per deciliter down to 100, my risk comes down by about 22%. If I lower my LDL cholesterol by twice as much, so 76 points, right, then my risk comes down by twice as much, so about 40%. Ballpark, okay? In fact, when you look at all these trials plotted together, that's the trend you see. The lower the LDL cholesterol achieved, the lower the risk. Each of those squares is a separate clinical trial. Just a quick clarification, if you're a regular viewer, you already know cholesterol level isn't really what causes risk. Cholesterol is a marker. The problem are the vehicles that carry cholesterol in our blood, specifically the so-called ApoB lipoproteins. We have a ton of videos covering this in detail, so if this is news to you, by all means check them out. So statins lower cholesterol, but they also lower the number of vehicles, and that's why they lower risk. But for historical reasons, most of these trials looked at this marker. They measured LDL cholesterol, which is a reflection of the number of vehicles. Okay? Just to clarify. So, looking across all of these trials, the lower the LDL cholesterol achieved, the lower the risk. Notice that this is nothing special. Most risk factors work like this. If I smoke 1 pack of cigarettes a day, my risk goes up. If I smoke 2 packs a day, my risk goes up more. So risk is determined by the dose of the risk factor we're exposed to. In nerd speak, we say it's a dose-dependent effect. All right? Nothing surprising so far. Now, I told you that there are two major factors that determine risk. Dose is one of them. The second one is a little more interesting, And it's usually neglected in these online discussions, which leads to a lot of misunderstandings. We said that if I smoke more packs per day, my risk goes up. What else determines my risk? Even more than how many cigarettes I smoke in a day. Time of exposure, right? If I smoke 1 pack a day for 5 years, my risk goes up. If I smoke the same 1 pack a day for 30 years, it's way worse. So time is at least as important as dose, and maybe even more so. It's exactly the same for cholesterol, or really the particles that carry it, those ApoB lipoproteins. We understand that's the real problem, right? In fact, some authors have made this exact analogy. Atherosclerotic burden, so that's the burden of plaque in our arteries, can be expressed in cholesterol years. So factoring in both the dose, the level of serum cholesterol, and years of exposure. Analogous to pack years of smoking. We're not saying the risk factors are exactly the same. Oh my God, they're saying smoking and cholesterol are the same and they're dismissing the differences. None of that, right? This is just looking at the concept of exposure over time, which applies to most, if not all, risk factors. So let's take a group of people with an LDL cholesterol of 120. Pretty typical in Westerners. The plaque burden is going to increase over the years, and eventually it reaches a critical threshold. And people start to have clinical manifestations, like angina or heart attacks. They might reach this threshold at the age of 60 or 70. Now, if it's a group of people with familial hypercholesterolemia, their cholesterol and the number of vehicles carrying it is going to be much higher, and the plaque burden is going to rise much faster. And it might reach the threshold at 35. On the other hand, if it's a group of people keeping their cholesterol and their ApoB lower with lifestyle or a statin, the burden rises more slowly. And they might reach the threshold at 90 or 100, which would mean a lot of them would never have heart disease in their lifetimes. Now, obviously there are individual differences, like with any risk factor. Not every smoker gets lung cancer. So we can have two people with the exact same cholesterol level, exact same ApoB level, and yet have different outcomes, depending on individual susceptibility. But overall, statistically, the risk goes up with dose of exposure and time of exposure. A recent analysis that just came out last month confirms this. They looked at all these clinical trials where cholesterol is lowered with statins, and they found that the longer it's kept low, the larger the benefit. So after 1 year on cholesterol lowering treatment, risk was reduced by 12%. That's 12% per millimole per liter LDL cholesterol reduced, as we saw before, which is 38 points in the US, right? So 1 year, 12% lower risk per unit of cholesterol lowered. After 3 years, it was 20% lower. After 5 years, 23%. After 7 years, 29%. And for people with cholesterol kept low their whole life from birth, determined genetically, it was about 50% lower risk. All per millimole per liter. So lifelong risk is cut approximately in half for each point of LDL cholesterol dropped, or 38 points if you're in the US. Now, if you remember in the beginning of the video, we said those meta-analyses averaged out, found a 22% lower risk. That's because the clinical trials average about 5 years of duration. So for 5 years, it's about a 22-23% benefit per unit lowered. As these authors explain, the benefit of lowering LDL cholesterol is greater if initiated at an earlier age. The earlier we start, the less exposure to the risk factor and the less plaque is going to build up. Later in life, we're trying to avoid additional lesions, but there's relatively little we can do about the plaque burden that's already there. Yes, statins can help stabilize existing plaque, and maybe there's an effective reduction of existing plaque with drugs, maybe with diet, but it's generally a pretty modest effect. The biggest bang for our buck is in prevention. This is a crucial concept. Once the lesions have accumulated for decades, yes, we can do damage control, we can reduce risk, but the real game-changing potential is in avoiding the lesions in the first place. Going back to this image of accumulation of plaque burden, we can slow down the plaque growth by lowering LDL cholesterol at 50 years old, but it's much more powerful to lower it from an earlier age. Okay, so now we understand the two major factors, dose and time. Now we're ready to put this together. Lowering LDL cholesterol by 1 millimole per liter, or 38 points in the US, for a time of 5 years, we know that's about 22% lower risk. That's the number we started the video with, that average from all the trials. Now, we can increase this effect in two ways, by playing with dose or time. If we play with dose and lower LDL cholesterol more, the benefit is stronger. We lower risk by close to 40%. If we reduce by the same 1 millimole per liter, but do it longer, 20 years, the benefit also goes up. And if we combine both dose and time, the effect is maximized. This is why in cardiovascular research, it's often said that lower is better, but importantly, earlier is better. There's no point crying over the past. What's done is done. When you learn this stuff, you implement it, you do the best you can, and you move forward. Okay, so far, so simple. Now, a lot of people ask about absolute risk. Absolute risk, we'll see what the heck that means in a second, is usually a smaller number. So does that mean statins don't really work or are not worth it? In fact, a recent study looked at absolute risks, and many of you asked us to comment on it. Does this invalidate the whole thing? Is it all a hoax from Big Pharma to just sell drugs? And speaking of pharma hoax, a lot of people ask if we can even trust these statin trials because of industry funding. Now, we'll probably make a whole video about this at some point because it's a very common question. It's natural to ask. But for today, just a quick pass. Number one, there are trials that are not funded by pharma that also reported a benefit. And number two, other interventions not relying on drugs that also lower cholesterol, like diet, genetics, and certain surgeries, also reduce cardiovascular risk in a way that aligns with the results from the statins. In fact, the genetics show a stronger effect than the statins. So, if anything, these industry-funded statin trials underestimate the full potential. So this general idea I've heard on the internet here and there that we just ignore these dozens and dozens of placebo-controlled, double-blinded, randomized clinical trials with thousands of people because of some funding concern immediately crumbles when you understand the bulk of the evidence and the context where these trials fit. Let me know if you have questions or if you're interested in this topic in this angle, because we can make more content going over this in more detail. Okay, absolute risk and relative risk. What is this nerd fest? What do these terms even mean? Let's say I create a device that prevents car accidents. It's analogy time. So I'm all happy with my invention and I take it on Shark Tank and I pitch it to the sharks. First shark asks me, how effective exactly is your device? Did you test it? Yes, we tested it. We drove around the block 1,000 times without the device and 1,000 times with the device. Without the device, there were 10 accidents. So the risk of crashing was 1%, 10 out of 1,000. That's the absolute risk of an accident. And with the device, there were 0 accidents. So the risk is 0%. So the reduction in absolute risk is just the difference between the two conditions. From 1% to 0 is 1%. But relative risk looks at what fraction of the risk was eliminated. If the risk is cut in half, we say there's a 50% reduction in relative risk. If the risk is 4 times smaller, we say there's a 75% reduction in relative risk. But in this case, the risk was completely eliminated. We brought it to 0. So the relative risk reduction is the full 100%. So in this simple example, you can see that the relative risk reduction can seem very large, 100%, while the absolute risk reduction can seem very small, 1%. With the same intervention, this means the device was very effective compared to the control conditions. It eliminated all of the risk, but it didn't make a huge difference overall because there were very few accidents in the first place. The risk was small to begin with, which makes sense since we only drove around the block. The odds of crashing were low. But what happens if we drive around for 1 year or 10 years or 20 years? Then the risk of having an accident goes up. Let's say that over 20 years, my chances of getting into any accident are 50%. Now the device is magical. It brings the risk to 0 again. So absolute risk reduction is again the difference between the two conditions. Difference between 50% and 0 is 50%. And the relative risk reduction is 100% because we eliminated all of the risk. Notice that driving for 20 years, the absolute risk reduction ballooned 50-fold from 1% to 50%, right? Just by driving much longer, which increases the risk of accidents in the first place. So the realization here is that absolute risk reduction depends heavily on the risk in the control group before the intervention. It's exactly the same for risk factors and disease. Let's take an imaginary risk factor X. We look at a group of 45-year-olds exposed to this risk factor. and we follow them for, say, 5 years, and we measure the number of deaths. The curve barely goes up, only a small percentage die, because it's a short window and they're relatively young. Now we look at another group of 45-year-olds without the risk factor. Even less people die, almost nobody. The difference between the two groups seems pretty small, because there aren't that many deaths to begin with. But over time, the risk of death rises and the difference gets larger and larger. Okay, I actually owe you an apology. I totally lied to you just now. This isn't an imaginary risk factor. This is actual data for smoking. In this study, they looked at mortality from lung cancer for smokers and non-smokers. You have to look at people who already smoke. You can't ethically randomize a population to smoke. After 5 years, the absolute difference was small, a fraction of 1%, because there aren't that many deaths yet. Less than 1% of smokers had died. So the absolute benefit of not smoking is capped at that number. The most deaths we can avoid is that small number below 1%. But with time, there are more and more deaths in smokers, and the absolute benefit of not smoking becomes more and more dramatic. It's exactly the same with cholesterol. Over a short time window, a relatively small percentage of people are going to have a heart attack. So the absolute benefit of an intervention is capped at that small number. Even if the intervention is amazing, there's only so many heart attacks to prevent. But as the time window increases, risk goes up, and the absolute risk reduction can go up as well. Here's an example. This study looked at cardiovascular risk for people with different levels of serum cholesterol. After 5 years, the difference was modest. The group with higher cholesterol in red only had 1 or 2% higher absolute risk. But the difference gradually increased with time. And 15 years later, it had grown by 8-fold. Now, in practice, absolute risk is going to depend on many factors, like how old or how sick the population is. And some analyses do show large absolute risk reductions, even over 5 years, especially if they look at big differences in LDL cholesterol level. This one, for example, found a 28% absolute risk reduction, which is massive. The group with the highest cholesterol had a 32% chance of having an event, versus 4% for people with the lowest cholesterol. But in general, you see smaller absolute effects over the short term that increase with time. These authors worded it pretty unambiguously. The absolute risk reduction can be improved up to 10-fold simply by maintaining lower lipids beginning earlier in the disease process. Now, looking back at the tobacco data, notice that even though the absolute risk is low over 5 years, a fraction of 1%, the relative improvement is already very strong. Essentially, all of the risk was eliminated. There's almost no death in non-smokers. So the relative risk reduction is very high. It's close to 100%. What happens in drug trials is very similar. If a drug is effective, you tend to see a benefit relative to the control group early on, a few years in. But absolute risk can take many years or decades to rise, as more and more people in the control group have heart attacks and die. It's actually unethical to let a trial drag on after you've clearly seen the drug work. So trials are sometimes stopped early if the relative benefit is clear, long before the absolute risk has had time to rise. So looking at the absolute risk reduction from a 5-year trial and saying, well, it seems like a small number, so I guess the drug didn't work or it's not worth it, it's a basic misunderstanding of what a trial tests and what it means. Another common question is, why is relative risk normally reported and not absolute risk? Well, the relative risk reduction is a more generalizable measure of the effectiveness of a drug. The absolute risk reduction is more sensitive to the specific context, how old the subjects were, how sick, the length of follow-up, etc. So the absolute risk reduction tells us more about that specific experiment, while the relative risk reduction gives us a general idea of what the drug can do. It's more transferable to other contexts. Now, some people argue, just tell people both. Give them the relative risk and the absolute risk. And I agree with that. Tell people how much the drug can lower their risk and tell them what their risk is in the first place. Absolute risk. But this is not the 5-year absolute risk from the trials. Sometimes I see people suggesting giving that number as a measure of absolute risk. That's a misunderstanding, and it's easy to see why. If a doctor is talking to a patient about quitting tobacco and only shows this, the first 5 years of benefit, and says, look, Your absolute risk is small anyway. It's a fraction of 1%. So quitting only reduces your risk by less than that, so why bother? This is worse communication than not bringing up absolute risk at all. You want to give the patient an idea of the full benefit of not smoking. That's what's on the table. Same for cholesterol. Saying that the absolute risk reduction over 5 years is just 1%, so don't even bother bringing down your cholesterol and your ApoB, is just a basic misconception of how risk factors and chronic disease works. Just to give you an idea, absolute risk, as we said, depends on many factors, how old the person is, how sick they are, but over the long run, lowering our cholesterol can lower our absolute risk by 10%, 20%, up to 50% if the cholesterol is very high to begin with and the risk is very high. So that's a staggering effect by any standard. Optimizing risk factors for a short window delivers modest benefits. Optimize them in the long run and the benefits grow. Here's the bottom line for this whole video. Absolute risk is a measure of the prevalence of a disease in the population, of how common it is. It'll be low for rare diseases and it'll be high for common diseases. Cardiovascular disease is one of the most common, one of the most prevalent diseases in our society. It's the #1 cause of death in the world. So cutting the risk by 50% over the lifetime, or even a fraction of that, would revolutionize human health. If that's not worth it, then no disease is worth addressing. It's like investing, right? Where your profits compound over the years. Well, avoiding risk factors is an investment in your future health, 10 or 20 years down the line. Just had to sneak one last analogy in there. I can't help myself. We'll stop here for today. I don't want this to be too long. There's also something called number needed to treat, or NNT, that people sometimes talk about. It's just another representation of absolute risk reduction. So we can touch on that in future videos if there's interest. And we'll definitely talk about the side effects in detail. So let me know your questions. Thanks for watching. See you next time.